Hello, my name is Dr. James R. Golding, and you're watching A Natural Healthcare Alternative, the program dedicated to your health, longevity, and well-being. Today's program is going to be on neurodiagnostic testing. It's going to be part of a two-part program that is going to educate you on the use of this testing and how it may be appropriate for you. And then we're going to demonstrate it on our next visit. We're going to talk about its clinical applications and basic use in helping people to get better. For the past few years, I went back to school to undergo certification for neurodiagnostic testing, which I recently received. This testing is not new. It has been in use by medical doctors for many, many years, but is now being utilized within my practice. And I wanted to talk to you about its use in clinical application. Neurodiagnostic testing is an adjunct to physical examination and other tests for the determination of musculoskeletal, nervous system, and central nervous system problems. Not everyone that comes to see me with a musculoskeletal problem needs to undergo neurodiagnostic testing, but there are many applications where this helps to clearly define the nature of the problem, where it's located at, and thus allows for the best treatment modem and most effective treatment while undergoing care. Neurodiagnostic treatment is good for numerous things. Number one is peripheral neuralgia. That means neurological problems stemming from both your arms down and from your legs down. The other is something called radiculopathy, which we'll talk more about. That is a radiating nerve condition that stems from either the neck or spine and creates radiating symptoms into regions of your trunk, into your back, muscle wasting, things of that sort. The diagnostic testing also is inclusive of, it checks for metabolic problems that may be existing within the system. It checks for congenital problems. It also helps to diagnose multiple sclerosis. We could also check for toxicity, neurotoxic problems that may exist in the system. And that's those are its main clinical usages. Also something called myopathy, muscle wasting, muscle diseases. These applications with this test is indicated. Now, I'm going to talk first about peripheral neuropathies, because that's the most common reason of why I would do these tests on a person coming into the office. We're seeing a dramatic increase in my office in patients coming in with carpal tunnel syndrome, or what's called perceived cervical radiculopathy. Very common symptom now, especially with the use of computer, with repetitive use situations in the hands, pregnant women, people that are put on excessive weight in a short period of time. It can happen through injuries to the wrist or arthritis. People will lose strength and power into their hand. They'll get radiating pain and numbness into their hand, especially at night. They'll feel like they need to shake their hands to get it back to life, and bring it so that they can get your symptoms back in. It used to be that patients had isolated carpal tunnel syndrome, but now what we're finding is that it's frequent for people to get what's called a crush syndrome, meaning they're getting tendinitis into the forearms and hands. They're getting nerve entrapment in different areas, starting from their neck down, due to particular holding patterns and stress and tension that's accumulated in their daily life. Now, the instrument that we use to check for carpal tunnel syndrome is a neurodiagnostic evaluating machine, or an EMG or an NCV machine. And what we do is the patient would come in. This takes about an hour to undergo this test or procedure. And what we're utilizing is an instrument where we're applying recording devices on the hand in different positions, and we're applying an electrical stimulus that sends a signal down and measures whether there's any nerve entrapment or encroachment occurring at the actual wrist itself. Many times people will have symptoms here, proximal or distal, that may not just be coming from here, but maybe coming from other areas. So what this instrument does, it allows for us to clinically measure whether and where and the degree to which there's a deficiency of nerve supply that's going into the hand. Now let's take a moment out and go over the neuroanatomy of the hand. And what we're seeing here is that at the level of the wrist, there is a tunnel, and it's called the carpal tunnel. And that tunnel actually comprises numerous tendons, some blood supply, and the median nerve. That region right there is an enclosed region of ligament tissue around which we have a flexor retinaculum, or a band that goes across the top. This region has become subject to compression that degenerates or causes what's called a demyelination of the nerve, meaning there's different types of nerve problems. We have a problem with a nerve being damaged, okay? We have a problem with a nerve being compressed, which is called a neuropraxis. Then we have something called demyelinization of the nerve. Now what that is, it's actually the covering of the nerve, just similar to a covering of a wire, becomes compressed and compromised. And this allows for an incomplete signal to occur from your brain down to where the muscles and adjunctive sensory nerves occur. So there's two types of nerves that are in the periphery. One are sensory nerves in the periphery, and the other would be motor nerves in the periphery. So what this instrument is measuring is both the sensory and motor nerves that go into the involved region. Now, there's numerous nerve supplies that we're measuring from the neck down into the wrist, and those nerves all stem from junctions up into the cervical spine. The electrical stimulus is applied at different junctions along the way that allow for us to see whether there's any impedance in the actual nerve flow itself. Now, the beauty of the instrumentation with carpal tunnel syndrome, and keep in mind this is the definitive test for carpal tunnel, is that we could actually isolate the exact point where the nerve is being entrapped or compressed, and as a result, it allows for much more effective treatment. Most of the time, something like carpal tunnel is a conservatively treatable problem and is not something that needs to be treated surgically. So we can manage it much better when we isolate the exact point, and we can get down right to the point through what they call inching, along with the neuro testing equipment, of the exact location where the compression's out, so we can cause a release either using acupuncture, cold laser, manipulation, use of corticosteroids, braces, home therapy, and exercises. Once we've isolated the exact region, it allows for much better care and evaluation. Also, if it's something where we can tell if the degree of the problem is so severe that conservative care is not going to help the condition, then we know that right away. So then it's a situation where the patient's getting the most effective treatment in the shortest period of time for the nature of their condition. Now, separate from going down and testing nerves down into the arm to check for different locations, because there can be entrapments that occur at the elbow, there can be entrapments of nerve supply that go into the forearm, it can come up into the shoulder area, and there's numerous diagnoses that go with that condition. Getting that diagnosis correct allows for the most effective care and treatment that you can possibly get. So after we do the distal nerve conduction studies, meaning checking the nerves along the course from this region of the brachial plexus, or this group of nerves from your neck, down into this region, what we're doing next is that we're checking then the nerve supply from the spinal cord all the way down in reverse. So we're sending signals back up to the spinal cord, and we're allowing to figure out the exact location where nerve compression or inflammation or agitation occurs. Now, why we would do that for the neck is that it's very common, like normally we just don't jump into the nerve testing. We're doing physical examination, we're doing MRIs of the neck. But what we find frequently is that people with neck problems don't have an isolated neck problem. They have numerous areas of dysfunction in their neck. They may have multiple disc herniations in the neck. They may have something called spinal stenosis. Now, in referring to our chart here, what we're looking at, first of all, is this distribution that shows in the arm. This is what they call dermatomes. Dermatomes are what you feel on the surface on these levels correspond to a certain region in the neck. So what happens is that when we do nerve studies into this region, sensory-wise, it helps us to correspond into these regions of the neck. So also, it helps us to isolate where the exact level of compression and inflammation is occurring. People will frequently suffer from what's called spinal stenosis, and spinal stenosis is either acquired or congenital compression of the nerve supply, either within the spinal cord, or within the spinal canal, or within what's known as the spinal nerve roots. People that have this, they have this at multiple levels, and what happens is that it's very important in the care, treatment, and evaluation of the patient to actually determine the exact level of the causation of the problem. So the nerve conduction studies allow us to isolate where the problem's at in the periphery and where the inflammation may be occurring at. The adjunctive component that we do as part of the treatment is called an EMG. That is provided by a medical doctor that works with me, that we actually go and we use the nerve conduction instrument, and we're actually sticking a needle into muscles that relate to certain spinal regions of the neck. So that allows us to isolate the level of the radiculopathy of the neck, meaning the exact causation of where that pinching is located. So what we have is we're locating the level at which the problem is occurring at. We're locating the actual spinal nerve root involved, so that allows us to get better care, evaluation, and treatment, and allows us to determine, is the nature of this problem a permanent nerve condition? Is the patient changing? Was the nature of the condition a recent thing? Let's say in something where a person suffers an automobile accident and they start to develop a radiculopathy or radiating weakness into the arm or upper extremities. What happens is that these tests, after a short duration of time, usually anywhere from 3 weeks to a month following an injury like that, will allow us to pick up the level of the nerve damage, how severe it is, whether it needs any form of additional care and treatment than what has been rendered before. So this machine allows us to document the nature of the injuries to support the requisite care needed. Now, in today's managed care, it's very important to get the proper diagnosis in the shortest period of time. This makes it so that a patient isn't undergoing what I call care through attrition, meaning getting care, okay, that didn't work out, getting some other form of care, okay, that didn't work out. What these forms of evaluation allows us to do is to get right to the point in the shortest period of time, so that we can measure and clinically evaluate that, so they're getting the treatment in the most adjunct, in the shortest period of time available. So when we're looking in the lower extremities, what we're doing is very similar to, like, if a person has sciatic neuritis, let's say, okay, which is a radiating pain from the nerve in the lower back, very, very common, that comes into the leg. Once again, most of the time that people come in with sciatica, which is the number one thing that I see and treat, they don't need the nature of this testing, because we've isolated the level through physical means and MRIs and X-rays, and without needing to go into further evaluation. But when and if a patient reaches either a plateau or they have muscle wasting or degeneration or they're not able to walk appropriately, we need to get that deeper evaluation that comes through the nerve conduction studies and also comes from the adjunctive EMG study of the involved area. Now, what happens is that when we're doing with the nerve conduction studies, what we're doing is a few different studies in the lower extremities. One is called a H wave, or what's called a Hoffman Reflex, and that allows us to send a signal, an electrical impulse or signal, from the lower extremities that comes back and radiates into the lower spinal level, into what's called the sacral region of the lower back. Knowing that there's an impedance in that area allows for us to key in the treatment into that area, which may either comprise decompression therapy to the spine. It may involve sending a patient to have an epidural of the lower back, which is an injection of a cortisone into the involved area. Once we know that the exact level, it allows for a very, very, very effective care and treatment. The other form of electrical frequency that we send up into the body is known as an F wave. An F wave sends up a signal on a repeated basis that goes into what they call the afferent region of the spine. It checks out the sensory component of where a person's pain may have its origin. Because when we go back to our spinal chart, and this being your brain up into here, this region is your spinal cord, and this is your spine opened up in the back area. Your spinal cord actually ends at the second lumbar vertebra in the lower back. Most people, they start to develop problems from what they call the spinal nerve roots coming from the end of the spinal cord. Those spinal nerve roots then come out what's called intervertebral foramen. These regions are very suspect towards injury, and is one of the most common neurological regions occurring in what's called the IVF of the spine. So when we do a conduction study and we do an EMG study, it is allowing us to isolate this particular nerve root. When we're doing the F wave study, a lot of people, they find now, are getting their pain is being caused by what's called the dorsal root ganglion. It is something outside of the nature of within the spine itself. So that reflex allows us to isolate whether the sensory portion of their pain is coming from that neurological region. Why is that additionally important is because sometimes people have chronic pain, and in the absence of their MRI comes back and it's negative for there being any problem. We're not seeing objective physical means through either imaging of the spine, CT scan, MRI, X-ray evaluation, or anything like that. But because their pain may be coming from these ganglion, these nerve junctions outside of the spine, so what happens is that this neurological testing allows us to do the appropriate evaluation into that region. So for the lower extremities, the actual study is one in which we're doing the nerve conduction study of the major nerves that go into the lower extremities. We're doing what's called the H wave, the Hoffman Reflex wave that goes up and reflexes into the spine and comes back down. We're doing the F wave, which then sends a signal up to the dorsal root ganglion in the spine. So we're checking out the sensory neural component of what's going on. And then we're also doing the adjunctive EMG, which is the actual needle application where we're getting a signal from the muscle that is fed by the nerves of the back itself. The wonderful thing about that component of the test is that allows us to isolate the exact nerve root level. It's either at L5, L4, L3. if there's an adjunctive problem like that. So that's the reason why we would utilize these tests for, number one, clear elicitation for the level of causation of your condition. It allows us to treat it better. It allows us to isolate greater degrees of causation if there's multiple levels due to multiple level disc degeneration in the back, spinal stenosis, that congenital or acquired narrowing of spaces in the back due to nerve root inflammation. So all of those components we can elicit and identify through the nature of this testing. When it comes to the peripheral entrapments, we're also getting that information because frequently, as I mentioned before, a patient has carpal tunnel and they have tendinitis and they have pain in their neck and mid-spine. So they're getting a little of this and a little of that. But if we know where the primary pains are and where the actual additional areas of causation of the pain is, it allows for a much more effective treatment. When I started out in practice 30 years ago, I didn't find that I found that people, they had carpal tunnel syndrome, if that's what they had, or they had tendinitis, lateral elbow pain, or they had this cervical radiating brachial neuritis pain. But frequently now, due to these holding patterns and the stresses and the postural problems that people have now, they're getting what's called a crush syndrome, problems occurring on numerous levels. So that pinching can be caused at numerous points. So knowing the exact components that are related to that allow for thus the more care and effective treatment. Okay. The other type of test that we utilize less frequently is called an SEEP test. This is a signal that we're sending from the periphery, and we're sending that signal up through the spinal cord into your brain. And what that's allowing us to do is to check the nerve channels from the source or origin of where a weakness may exist to seeing whether a person has abnormal brain connection, or there's a problem in the midbrain, or is the problem in the brachial plexus, meaning the group of nerves that comes out of the neck. So this is also an adjunctive test that we would use to help to test for MS, if that's the case. And we also do something called visual evoked potentials that are also tests that we would do for MS. These are neurological tests where we're stimulating visual regions of the eyes that relate then back to weaknesses that occur on a brain level. So that, used in conjunction with MRI, would be the definitive tests associated, and blood tests would be associated with testing for MS and brain MRI. But the main focus of what's going on is the care and treatment, mainly with the radiculopathies, meaning the radiating nerve conditions in the lower back, and the peripheral neuralgias. Frequently, people are coming in to see me, and they have sciatic neuritis, meaning or a radiculitis, a radiating nerve condition, and they're also diabetic. So frequently in diabetics, we see numbness in the feet, tingling, abnormal nerve sensations occurring into their feet. So what these tests help us to determine is it part of their metabolic problem, meaning that the diabetes causing nerve starvation, or is that a part of the component of the radiculopathy or the radiating pain that they're experiencing? So we know then, we can sort out better treatments as far as what's more applicable for the patient in that regard. We have two different forms of nerve compression occurring, and one is either acute compression that's occurring to the nerve supply of the central nervous system, like in the case of a disease or an injury, where we have damage to an area. And then we have chronic nerve compression and inflammation, which may occur from degenerative diseases of the back, spine, musculoskeletal system caused by arthritis, pain due to poor posture, scoliosis, degenerative processes, metabolic imbalances, deficiencies that may occur. So frequently in acute conditions, it's much more easy to determine the exact level and the cause of a problem and where that's occurring, because it's a direct site of injury. In chronic cases, which is more of what we're looking at when in the care, evaluation, and treatment using electrodiagnostics, is that this gives us a sense of clarity of where that level is at. It helps us to sort out the muddled field of where the problem may exist. And within the nature of this testing, there is really no contraindications to the nature of the evaluation. There's some contraindications in regards to the needle EMG study, because we're doing invasive work versus non-invasive with the other forms of neurotesting. Next, we're going to go and actually do the testing on our next visit. I hope that this proved to be a little informative and help you with the clarity and the nature of this treatment. For Natural Healthcare Alternatives, I'm Dr. James R. Golding. Thank you for watching.